Okay.
Okay, so first I'll knock and introduce myself. My name is Christina. I'll be your nurse today. I'm just going to wash my hands really quick. Can you tell me your full name and date of birth?
Robert Johnson, July 23rd, 1993.
Okay, and I'm just going to look at your patient identifier bracelet. After I've introduced myself and checked his identifiers, I'm going to just start with an overall neurological assessment. First, checking overall appearance of the patient. He's dressed appropriately for the occasion. His affect is appropriate. He brightens with interaction. Then I'm just going to do some level of consciousness assessment questions. So I've already asked him his name, showing that he's orientated to person. Then I'm going to ask him the date.
It's May 3rd.
This shows that he's orientated to date. And then can I ask you where you are today?
NUSU.
And this shows that he's orientated to place. Next, over this time, I'm just kind of checking like speech pattern, make sure that he can hear me, he's clear when he talks. And then next, I'm going to go through the cranial nerves. I'm going to do 1 through 12, and then I'm going to say a way to test the cranial nerve, and I'll name the cranial nerve. So number 1 is the olfactory nerve. To test this, I'll just have my patient close their eyes, and then smell a familiar object. And then respond to what that object is.
Alcohol?
Yep. Next, I will name the optic nerve, which is number 2, and to test this, you can open up your eyes. To test this, I would just have my patient either use the Jaeger chart or the Snellen chart. For the Snellen chart, I have my patient stand 15 feet away, covering one eye, reading down the chart until he makes a mistake, and then switching to the other eye. Number 3 is the ocular motor. Number 4 is the trochlear, and number 6 is the abductus nerves. And for these nerves of the eye, I'll just have my patient look straight ahead, and then I'll have him track my pen light as I go throughout the cardinal fields of gaze. So I'm just looking to make sure that both of the eyes go together, looking in each area of gaze. Next is the trigeminal nerve. Number 5, for this nerve, I will ask my patient to just clench his jaw as I try and separate it, and I shouldn't be able to separate it. Number 7 is the facial nerve. For this nerve, I would just ask my patient to make a series of faces, and for this assessment, I'll just ask him to smile. So looking at both sides, making sure they're symmetrical, there's no drooping of one side or sagging. Number 8 is the acoustic nerve, and to test this, I can just test conversation between him and I, making sure that he isn't cupping his ear or excessively looking at my mouth to see lip syncing or anything. Number 9 and number 10 are the glossopharynx nerves and the vagus nerves. For these nerves, I would just ask my patient, I'm going to depress his tongue and say ah, and I'd just be looking to make sure that the uvula and the soft palate rise at midline, and the tonsils go medial. Number 11 is the spinal accessory nerve. To test this nerve, I'll just have my patient resist my hand to each side and to this side and press up with the shoulders. And number 12 is the hypoglossal nerve. To test this nerve, I will just ask my patient to say right, tight, and dynamite.
Right, tight, and dynamite.
Looking to make sure the T, the D, and the L are all clear and I'm able to understand those. Next, I'll do the deep tender reflexes, and I'm just going to see which ones I'm supposed to do. So first, I'll do the bicep. For this one, I'll just have him relax his arm, and then going against my finger. And then next we'll do the tricep. For this one, I'm just going to hold his thumb. And then for the quadricep, so I'll just hold I'll stabilize his leg. And that ends the neuro portion. Next, I'll move on to the cardiovascular portion. First, I'm just going to assess my patient's overall appearance, his overall color, his breathing patterns. Next, I would assess his extremities, looking for any peripheral edema and palpating to see if there's any pitting. And I would do the feet as well, both sides, looking for any edema pitting edema. Next, I'd have my patient recline into a 30 to 45 degree angle to assess his jugular veins. So in the reclining position, which he can't be in, I'd get at a line to him and looking for the pulsation, and at that angle his veins should be pulsating. Next, I would palpate each of the arterial pulses. Actually, she wrote those down, I think. Maybe? Oh, she only used to. So temporal pulses, carotid, looking to make sure that they're symmetrical on both sides. Brachial, radial, and I'll have you extend your leg here. Popliteal, and then posterior tibial. Making sure again that each side is even bilaterally. Next, I'll auscultate his carotid artery using the bell of my stethoscope. There we go. You lift your head straight up. Just listening to make sure that there's no bruise. After I'm done with that, I'll ask my patient to disrobe his front anterior thorax area. You can just sit. So then you can leave, sleep, or whatever. So just taking an overall assessment of my patient's chest. There's no lesions, no lumps, and it looks to be of a nice pink color. And then next I would assess his heart sounds. So first, using the diaphragm of my stethoscope, starting at the aortic position and listening for 30 seconds. Next, moving to the pulmonic position. Then the tricuspid. And finally, the mitral. Okay, and then you can put your shirt back on. Next, I'll move on to the respiratory system. Again, just taking an overall assessment of my patient. How is he breathing, the color of his skin, his posture. Then I'm going to take a closer look and look at his lips. They're a nice pink color, and looking at his fingernails and seeing that there's no purple or any cyanosis going on. Next, I have my patient, maybe turn your legs out this way. You maybe want to come.
Oh, okay.
So just taking an overall view of his back, looking that the spinal cord is straight down. His ribs, when he breathes, look symmetrical. And then I would palpate, looking for any tenderness, asking my patient, does this hurt when you're breathing or anything like that? Next, I'm going to do a chest or thoracic expansion. So I'm going to warm my hands up and put them on his lower thorax and ask my patient to take a nice inhalation and looking to make sure both hands expand symmetrically. Next, I'll do test for tactile fremitus. So I'm going to just place my hand throughout my patient's back, asking him to say 99 over each area.
99, 99, 99, 99, 99, 99, 99, 99.
Next, I'll percuss over his back. looking for residence throughout and dullness more towards the kidneys. And next I will auscultate using the diaphragm of my stethoscope. Take a deep breath in, and again, and again, again, and again, and again, and again, and again, and again, and again. Getting into the lateral aspects. Okay. And next, I'll have my patient disrobe the anterior thorax. Again, looking for an overall assessment, color, making sure that the ribs aren't sunken in or anything. And then I will palpate over the anterior thorax. Any pain or tenderness when I do this? Also checking for lumps or bumps, any crepitus when he's breathing. And next, I'll auscultate the anterior portion of his lungs. And take a deep breath in. And again, going over into the lateral areas of the chest. And that is it with respiratory. You can, and then next, ears. I have to do a makeshift tuning fork, but first I would assess hearing with my patient. First I do this by just conversations between the patient and I. Can he hear what I'm saying? Is he cupping his ears? Is he looking at my mouth excessively? And then next I would perform the Weber and the Rene test. And this will be my makeshift tuning fork for this exam. But first I would do the Weber. So I'd hit the tuning fork on my hand and then place it on the top of his head, asking him, can he hear it in the right side, the left side, or down the middle?
I would say down the middle.
Yep, and that would indicate a normal hearing. And then next I would hit the tuning fork again, place it on his mastoid process, and ask him to tell me until he cannot no longer hear the ringing.
Can't hear it.
And then I would move it over into the auditory canal until he could no longer hear the ringing.
Can't hear it.
And the airway should be longer distance than the bone conduction. Next, I would take an overall assessment of his ear placement. They both look to be even on both sides. No drooping or lagging of one side. And next, I'd inspect the overall outer ear. There's no redness, swelling, discharge, bleeding, or anything like that. And then next, I would palpate the pinna and the tragus. Feeling for any lumps, bumps, tenderness, no tenderness when I do that. And again with this side.
Nope.
Okay. Next, I would take my scope and take a look at his auditory canal. So I'm going to look at it and then pull the pinna back, rest my hand against, and turn on the light to see his canal. Making sure there's no excessive wax buildup, and the tympanic membrane is a nice gray pearly color with this cone of light at the 3 o'clock position. Then I'll move over to this side, and again looking at the canal here, there's no excessive discharge or anything like that, and then pulling the pinna back, pulling the pinna back, resting my hand and looking in there. Again, no excessive wax buildup, no blood or anything like that, and the cone of light is at the 7 o'clock position. Anything else? And I guess that's the end of my assessment.